The natural history of TB is more complex than that of most bacterial pathogens, and still not fully understood, even though it is an ancient disease. The incubation period is prolonged, and the outcome of the infection varies according to the hosts, the person infected, immune defense mechanism, and its relation to the pathogen. When compared with other airborne diseases, like the cold virus family, TB is relatively hard to catch and usually needs prolonged and close exposure to cause an infection. But due to often extended time periods between developing TB disease and starting treatment, contacts often have prolonged exposure. This diagram highlights all the possible outcomes after someone has been exposed to a person with infectious TB, including the percent chance of this occurring. For this cascade, the infectious TB is when a person has TB disease and is not on correct treatment. When a person has been diagnosed and started on the right TB treatment, they quickly become non-infectious, and this infection cascade stops. Between 70 to 90% of people exposed to a person with pulmonary TB do not get infected. Around 10 to 30% of individuals exposed to an infectious case of TB develop TB infection. A person with TB infection does not show symptoms and cannot transmit TB bacilli. Upon infection and as it progresses, the body starts to react to TB bacilli, which can then be detected with diagnostic tests. Approximately 10% of those infected with TB may go on to develop TB disease. There are certain factors that increase the risk that we will review in Module 2. When TB infection develops into active TB disease, the person with untreated tuberculosis disease becomes ill for several years until the body naturally heals on its own, but if it doesn't, the person dies. The case fatality estimates for non-treated TB are between 20% to 70%, depending on the severity of the disease. This diagram also shows which TB diagnostics can be used to diagnose TB infection. We will discuss this further in Module 3. Another way of TB prevention is by preventing the development of TB infection in those exposed to the bacteria. This is an area where vaccination may play a major role. Another aspect of TB prevention aims at stopping TB infection from progressing to TB disease. This is where it is critical to identify those with TB infection, those most likely to progress to TB disease, and to understand what preventative therapies can be offered to prevent this progression. This is the main focus for this course. Remember that, as estimated, even if TB transmission was stopped today, it would be impossible to eradicate TB before 2050 due to TB disease arising from the latent TB infection reservoir from 2014 alone. Thus, to meet the World Health Organization's End TB strategy goals, we need to find ways to prevent TB disease development in those infected individuals. The source of spread or transmission of TB bacilli and eventually TB infection in certain situations comes from someone already suffering from pulmonary TB, usually undiagnosed and/or not started on treatment. The person coughs, breathes, or sneezes droplet nuclei containing TB bacilli. The droplet nuclei, approximately 1 to 5 microns in size, may remain airborne for up to 6 hours. The scientific term of TB bacilli, germs or bugs, is Mycobacterium tuberculosis, as we learned in Module 1. People who live or work together with above people with TB are sharing the same air. That is, inhaling the same air with these droplet nuclei may then become infected. This sharing of the air or contact leads to exposure to TB bacilli. The uninfected person or contact inhales the droplet nuclei containing the organisms, typically into the lower lobes of the lungs. There, TB bacilli are met by the body's first line of defense, alveolar macrophages by phagocytosis. This is an innate immune defense. However, TB bacilli can avoid the destruction by macrophages due to its thick cell wall. The cell envelope of TB bacilli is complex and diverse, composed of proteins intermingled in a matrix of peptidoglycan, mycocholic acids, lipids, and carbohydrates. It allows TB bacilli to resist the acidification and bacterial clearance. These surviving TB bacilli continue to multiply inside the macrophage until it causes the macrophage to rupture. However, if they remain hidden inside the macrophages, they can travel through the lymphatic or bloodstream to any body organ. The rupturing of the macrophages attracts monocytes and other inflammatory cells to the area. Monocytes differentiate into macrophages and, once more, eat the TB bacilli. However, this time, TB bacilli will be contained within the macrophages without being destroyed. After 2 to 10 weeks of infection, T-cell immunity of the host, the person who was exposed, and inhaled droplet nuclei containing TB bacilli develops. The antigen-specific T lymphocytes arrive at the site of infection after being primed by monocytes or dendritic cells and proliferate within the early lesions or tubercles. Then they activate the macrophages, which leads to the formation of granuloma, which is able to kill the intracellular mycobacteria. In summary, if the initial response works properly, which should be for the case of people with healthy immune systems, remember Module 1. The exposed person eliminates TB bacilli and does not become infected. This means that all tests for TB infection are negative despite exposure. Other people may achieve complete elimination of TB bacilli after immunity activation, i.e., with the help of granulomas. For these individuals, the tests for TB infection may be positive, TST and IgRAs, because the immune system was exposed to TB bacteria. Finally, in certain instances, despite elimination of most TB bacilli, some may survive inside macrophages or granulomas. These can remain dormant, but viable for years, meaning the hosts have TB infection. Even with the infection, these people have no symptoms of active tuberculosis, nor are they infectious. These people are potential candidates for TB infection treatment, also called TB preventative treatment. The first stage of preventing TB infection is preventing the exposure of an individual to the mycobacterium. These prevention steps are linked to decreasing the exposure to TB bacilli. Other important preventative steps regarding the health of the person exposed, particularly with regards to their immune system, will be discussed in Module 2. Infection control aims to preventing and/or reducing the initial inhalation of TB bacilli through the implementation of a tuberculosis infection control plan, TBICP. The most important step in the TBICP hierarchy is to reduce the risk of exposure to TB bacilli by identifying and isolating individuals showing symptoms of TB, such as cough, until they are screened. If they are found with TB, start them on correct treatment. Environmental measures, such as ensuring good ventilation and allowing plenty of sunlight and UV light, also play an important role in controlling TB infection. In resource-limited settings, taking advantage of natural ventilation is essential. Personal protection measures may also be carried out by both the person with presumed TB via wearing a surgical mask or covering their cough with a tissue, and by the care provider via wearing an N95 respirator. Environmental and personal protection measures play a role, but the key element is identifying people with infectious forms of TB and starting them promptly on the correct treatment.